really nice job. Okay, to warm us up for our lunch break, we're now going to go into the special joint session on nomenclature. And this session was inspired by the Non-Governmental Organizations Committee as well as the Multi-Etiology Committee, and many others have taken a strong interest. So I would like to start probably with our primary instigator, Angela Taylor. Would you please come to the podium?
Right behind you.
Oh. You're right there.
Hi, everybody. It's an honor to be here and to be part of this event. I was here 3 years ago. Really exciting as a patient advocate to watch the process, participate in the process, and to weigh in as the process unfolds over the years. My goal today is to open a national dialogue on behalf of all of the patient advocacy organizations that were represented up here. We feel it's time to have a dialogue about the terms we use when we talk about dementia. That's going to require that we identify in advance the needs of the key audiences and the stakeholder groups. When we talk about dementia in general, regardless of what the underlying etiology is, looking at the specific clinical syndromes that are represented today and in the other summits, and also the actual underlying etiologies, whether there's one or many of them. Words clearly matter, and I was looking for a quote that would help really make the point that I didn't feel like I would be articulate enough to do on my own. So I'm just going to read this. Some words and metaphors are used liberally and paint a very biased picture of dementia, while others are avoided and considered demeaning, depersonalizing, and insulting. Even standard medical terms are sometimes used with great caution due to an awareness of the possible impact on people's lives and well-being. Words clearly matter. They describe, communicate, and reinforce our current perceptions of dementia. With awareness, we can try to use them positively to challenge portrayals of dementia and promote a more positive image of dementia and people with dementia. I think changing a lexicon isn't easy, but I think it's extremely important, and it's necessary that we tackle it no matter how hard it's going to be. And we're not the first to propose some change. As I did some research for today's presentation, I found a number of organizations across the world who are really proactively trying to take a stance to really make the world a little friendlier place for families who are dealing with dementia. In the UK, there's a program called the Dementia Engagement and Empowerment Program, and this is really being driven by people living with dementia themselves to raise public awareness. In Australia, they've developed dementia language guidelines, identifying words that are really stigmatizing and create, even in a sense, emotional burden on the families who are living with the dementia, creating more inclusive language recommendations and things that are non-stigmatizing. And in the U.S., based off of some efforts in Minnesota, Dementia Friendly America. These are communities that are being brought into more awareness about dementia and the needs of the families who are living with it, providing safe and respectful options for them when they work with service providers, retailers, and all sorts of different sectors in their community, just to foster a better quality of life. When we look at what's going on here in the U.S., you'll see that there's various terms being used when we talk about Alzheimer's or dementias or related dementias across even different federal agencies. So in the National Plan to Address Alzheimer's Disease, as you all really well know, it is inclusive of more than just Alzheimer's disease. But the plan largely refers to Alzheimer's disease. And I'll tell you that in my discussions with representatives from other disease organizations, especially outside of the dementia sphere as a primary symptom, there were organizations that deal with dementia that weren't as in tune with the fact that this plan was very relevant to them as well. So we have to really look at this here in the U.S. so that we have a greater engagement of all of the different stakeholder groups. So in the national plan, we use ADRD as an acronym, but at sometimes they're referring to that as kind of all dementias in general, Alzheimer's disease and related dementias. But at other times, especially for this meeting, it's Alzheimer's disease - related dementias, and that's confusing. We can do a better job. The Department of Health and Human Services, as part of the National Alzheimer's Plan, has a public awareness campaign. But if you go to the website that's listed here, it really focuses only on Alzheimer's disease. And there are a lot of related dementias that need to have more visibility to the general public. Even the Centers for Disease Control, they have their own language. In their Healthy People 2020 initiative, they use the term dementias, including Alzheimer's disease and other dementias. I know that we can do a better job to come up with some consistent language. So this slide is an example of, to me as a layperson, part of the problem. We have so many different terms that overlap, and some of these terms are very important for the stakeholder groups that they were developed by and who they're used mostly by. But a lot of this overlaps. Even within this meeting, you hear a lot of the same diseases being referred to slightly different. Lewy body disease, Lewy body dementia, dementia with Lewy bodies. My favorite is the overlap Lewy body disease, Lewy body disorders, and Lewy body dementias, all meaning 3 different things. In every disease, you'll see these variations. Alzheimer's disease, or the new diagnostic criteria that says dementia due to Alzheimer's disease, frontotemporal dementia or frontotemporal degeneration. There's reasons for these evolutions, but they get confusing, especially when we talk about the lay public and the people who are dealing with this and what they need to be able to articulate back and forth with their doctors, their care providers, et cetera. So when we looked at this as an NGO committee, we really identified 3 different stakeholder groups. The patient and care community, which includes obviously all patients and caregivers, but is inclusive of the health disparities communities, all of the providers who offer services to those communities outside of direct clinical care, and the patient advocacy organizations as well. The healthcare system includes both the providers and the payers who have their own unique needs. And the scientific and regulatory communities have certainly the most highly specific needs. We want to make sure that we understand the unique needs of each stakeholder group and that we strive to develop a lexicon that meets their needs both in detail and then also at a broad level when they speak across stakeholder groups to each other. So I want to break this down a little bit by stakeholder group so that we can see how nomenclature can help evolve evolve the progress that we're making and actually have meaningful outcomes. So from a patient and caregiver perspective, early differential diagnosis, we all understand how important that is. But can nomenclature be leveraged to improve symptom reporting and to improve physician awareness about the different types of dementia? We heard a lot today about the primary care physician level of their ability to diagnose dementia, but it's not just their ability to diagnose, it's their familiarity with these diseases in general. We want to talk about how do we improve quality of life and slow the disease progression, possibly by leveraging better terms as we go into the process of increased access to safe and effective therapies, or recruiting patients to participate in the clinical trials that will result in those safer therapies. Improving access to care and services. We need, as a society, to be clear that when we talk about services for families affected by dementia, that those services are largely relevant to all of us who are dealing with any form of dementia. And that is a challenge, and I'll share a little bit more with that a little bit later. The appreciation of personhood, regardless of our level of cognitive impairment. There's a tremendous stigma, as you all know, about dementia, but how can we use the lexicon to improve that? From a health disparities community, I will be the first to admit there's a lot that I don't know, and I know that there's a lot that we as a community of dementia stakeholders don't know and want to know better. So all of these needs are really question marks. They're possible needs that we have to invest in further to understand how language affects them. Can we increase the proportion of people who receive a dementia diagnosis by using different terminology? Can we provide more culturally sensitive education and support by tailoring our dementia education and programs for the health disparity communities? And from a prevention strategy standpoint, can we increase the trust with the scientific community by understanding their needs, approaching them with sensitivity, and bringing more of them into research studies. From a stigma perspective, we have seen so many disorders come before us that are no longer discussed in whispers or discussed with embarrassment. And here are just a few. Certainly, you know, I was young when the awareness of HIV/AIDS came up, and that really was impactful to me personally. And now over time, as the decades have evolved, I don't have nearly the same sense of stigma that society and individuals really associate with this as a disease. Erectile dysfunction, hallelujah, thank you, Viagra, Cialis, you've done a wonderful job making a problem that affects many people accessible. We can talk to our doctors about it. We can joke about it. Cancer is no longer whispered. And mental health disorders, speaking as a parent with a child who has one, these are now part of the everyday conversation among teens and adolescents. There's not the same stigma associated with it. Why can't we do more with that from a dementia perspective? But I think that's going to require two things. That's going to require that we all put a concerted public awareness effort together where we are using similar language and we articulate that this is a medical condition. I think there's a lot of misinformation, a lot of assumption about what it is, what it isn't, and what can be done about it. We also need the patient community to stand up, speak about living with dementia. And I know that there are a lot of people, Michael Ellenbogen, thank you for being here, being one of those people standing up and saying, I'm still here. I may not function the same, but I'm still here and I still matter and I want you to listen. From a public awareness standpoint, when we talk about the language that we use, we have made tremendous strides because of the work of the patient advocacy organizations that are here. We have seen amazing public awareness grow on Alzheimer's disease. I'd like to thank the Alzheimer's Association for the work that they have done in being a leader in taking this to the national platform, especially from a legislative standpoint. This is bringing greater federal resources, also, again, under the banner of Alzheimer's disease, that are benefiting all of us who've been touched by a related dementia. But it comes with a downside. Right now, if you ask most of the general public, they won't be able to tell you what the difference is between Alzheimer's and dementia. There's very low public awareness that there are other forms of dementia. And in my personal standpoint, I like to think of myself as a relatively intelligent person. But when my dad developed Lewy Body Dementia, I didn't know that those services that were out there for families dealing with Alzheimer's disease had any relevance to me. I don't think I'm alone. And I don't think that it's acceptable for us to use one term when we're talking about a broader disease type. So from the healthcare system, and I'm only going to talk about healthcare system briefly and also about the scientific and regulatory standpoint, because we'll have another speaker after me who does a much better job at that. But obviously, we need sensitive and specific diagnostic criteria for both the prodromal and the clinically evident syndromes, clinical milestones that help physicians know when to refer their patients out, but have those milestones been defined? Are we going to be able to communicate to them when the family is here, you need to do this, so that they are not struggling to find resources to help them stay in their home longer? Certainly, language that can be communicated across different care settings. Having said that, we've got to keep a couple of things in mind as we talk about what the language could or should be. We need to make sure that we can effectively inform the patient and the caregivers what their clinical syndrome is, whether we know it or not, based on biomarkers. So what is their cognitive status? What is the clinical syndrome they're presenting with? And what are the possible underlying etiologies at play? There's a lot of work that went into DSM-5, and we want to keep that in mind as we look to see what can we do to improve the language that we're using now. And certainly on this scientific and regulatory side, we've had a lot of discussion today, and that's going to continue on the differentiation between the one or many underlying etiologies and the clinical syndrome. Looking at the difference between the disease stages. Preclinical, prodromal, symptomatic, are we all using those terms to mean exactly the same thing? And I say that by saying, does prodromal mean at risk, or does prodromal mean likely to develop? We need an efficient regulatory pathway. How do the terms that we use from underlying etiology all the way up to broader syndromes affect that pathway? So again, we need to be mindful of the evolution that we've already seen in different diagnostic criteria. There's a lot of work and a lot of thought that went into that, and we just can't derail that work that's already come to pass. We need to recognize that the need for those clinical pathological correlates are going to help us understand how to diagnose those disorders early, track what may come to pass as these different syndromes evolve. And certainly, that political momentum. We've seen all of the work that has been done in recent years to bring us to this meeting and the one in 2015 and 2014 and 2013 and 2012. And we can't derail that. This may be an evolutionary process where we have to make small changes, but it doesn't mean that we don't make any changes. So we need to keep that in mind. How do we continue to build the momentum going forward so that we have greater funding, greater attention of the different federal agencies working together, and at the same time keep an eye on global efforts? So my question to you today, so my presentation has no answers in it, so I apologize if you were hoping that I would offer some. It's really about what questions should we be asking? Is it time for us to consider something more of a bullseye format, where at the broadest level, we're really talking about an umbrella term for dementia or cognitive impairment? As we get more narrow, are we talking about the clinical syndrome? And as we have biomarkers that can be very specific, are we talking about the etiology itself or the disease mechanism? Can we use a model like this? I don't know. But should we be asking ourselves that and having really challenging conversations? Absolutely. So the recommendation from the non-government organization committee is that we organize a working group of dementia stakeholders, and that includes founding partnerships with the disparities communities to review the current nomenclature used in public awareness, clinical care, and research, and to propose strategies to help advance early diagnosis and the understanding of dementia and its underlying causes. Thank you very much.